Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Hello guys, welcome to our dental webinar series. Today we are going to have two presenters, one from the United States in Michigan and a professor from Egypt. And it promises to be an exciting, very educative time. All right, so we do have Professor Mohamed Ayad, a professor of prosthodontics from Tanta, Egypt. He will be speaking on prosthodontic management of thin-walled root canals, clinical and experimental considerations. We also have Dr. Michael Rodillo from the University of Michigan, an endodontic resident. He's going to be speaking on relating pulp biology to a typical endodontic case. Gentlemen, thank you so much for coming on our program today. I'm going to stop sharing my screen. Professor Ayad, please go ahead and share your screen and take it away.
Okay. Okay, thank you guys. Good morning, good afternoon, good night, wherever you are. Does it okay? The sound is okay? The sound is okay?
Yeah, we can hear you.
The sound is good.
Oh, okay. So I'm giving my presentation from a city called Tanta. It's northeast of the capital, around 60 miles. My brief talk today about the prosthodontic management of flared root canal or thin-walled root canals. I'm giving some clinical as well as experimental considerations. Before starting, I'm going to raise some point from textbook guidelines, as we know that before applying any final restoration or initiating an endodontic therapy, we have to have an assessment to the overall prognosis for the tooth that's going to be restored. So we have to evaluate the tooth, or we have to ask ourselves if the tooth is restorable in terms of prosthodontic or endodontic point of view. What is the prognosis, or what is the status of the periodontium? What is the condition of the other teeth in the arch or remaining entire dentition? Also, what is the overall treatment plan for the patient? What is the patient objective and motivation? And we have to apply some economical consideration before treating such patient. Reason for treating such tooth rather than having or taking this tooth out and applying an abutment, you already know that in some countries, let's say the third countries, we have to have some alternative treatment to reduce the cost for the patient as far as they do not have insurance. So regarding before starting our prosthodontic treatment, we have to evaluate like a proper root canal obturation or root canal treatment. This will include no signs of sensitivity to pressure, no exudate, no fistula, no apical sensitivity, and no active inflammation. Plus, as a textbook guidelines, we have to have 3 to 5 millimeter good apical seal. So what is the basic principle to apply the post or the dowel to the endodontically treated teeth? We have a preservation for the sound tooth structure. We have to apply a retention form and a resist. Preservation of the sound tooth structure, this will include preparation for the canal, preparation for the coronal tissue, and incorporation of the farewell effect to help prevent the root fracture. So I'm not going to talk about the basic for the endodontic or the basic for the post placement, but I have to raise only 2 points from selecting the post to treat the flared root canal. First is the post length, where there is no doubt about the idea of having the better retention by having a good post length. In the other word, the greater the post length, the better retention will be, as well as the stress distribution. However, this is not always possible, especially when you have short curved root canals. Remember only to have a 3 to 5 millimeter good apical seal. So there is no dilemma, or there is no doubt, or there is no conflict between investigator or clinician regarding the post length. However, if we go further for the post diameter, here is the dilemma, or here is the doubt regarding the diameter. There is too many theories that applied to the post diameter, as far as no research work talk about the increasing retention by increasing the diameter. It does not compare the post length. The theory that explains the post diameter varies between conservation theory, preservation theory, or proportional theory. One that talk about theory requires a minimum root canal preparation to maintain as much as you can residual tooth structure for the root canal. The other, who support the preservation theory, maintain at least 1 millimeter around the post space. And lastly, the proportional theory that postulated that the post width should not be greater than 1/3 of the root width as its nearest dimension. So, in a conclusion, we have to mention that the strength of an endodontically treated teeth is directly related to the amount of remaining sound tooth structure. And here is the question: what we have to do with the thin-walled wheel or the flared root canals? So, our statement of problem that a flared root canal always presents a challenge to the dentist when selecting a restorative material. As far as we know, a cast post and core is the commonly used for such affected tooth. However, because the morphology is going to fit exactly the canal. However, there is a problem with the use of the cast post and core in terms of aesthetic consideration when we talk about restoration of an anterior tooth. Also, remember that the metal does not have any resilience comparing with the resilience of the tooth structure, or the elasticity of the metal is completely different from the modulus of elasticity of the tooth structure. Also, in some clinical study, they have shown that the flowable composite in present with the fiber post could be used for relining the flared canal. This is what I'm going to show today, but before starting my clinical case, I have to mention that I do not have any conflict of interest for the material, the equipment, the instrument I'm going to use. What we got here, we got a patient, a male patient, is around 35 years old. And this is the preoperative view for the patient. We could see that tooth number 9, or the maxillary left central incisor, having secant fracture. History for the patient, showing that his medical history is unremarkable. However, his dental history showed no pain for the affected tooth. The intraoral examination for such patient showed that if we are going to remove the caries from the affected tooth, it would be left with a thin flared dentine canal walls. Also from the dental exam, there was no mobility, no tender, the tooth was not tender to percussion, there was no evidence of swelling. Also, there was no periodontal pocket related to such tooth. The radiograph showed no sign of radiolucency related to the apex. So, a consent form was taken from the patient and an explanation was given to him regarding what we are going to do. So our line of treatment was try to do immediate endodontic treatment, relining or reinforcement of the thin-walled root canal by a flowable composite, and later buying a kind of more resilience post in terms of fiber reinforced post, and having the composite core followed by extracoronal restoration. So a routine endodontic treatment was done. The working length was determined, and filing and reaming of the root canal was established. So the good thing, or the new elegant solution which we did use for this, was the 20% lactic acid. And the question is, why we did use a 20% lactic acid? Because lactic acid is a normal product of fermentation of many vegetable material. It's produced by some muscles in your body and by others. But also, lactic acid, based in one of our study, was able to remove the amorphous smear layer from the root canal, flush out the bulbal debris from the canal space, and a little bit remained from the residual of the dentinal tubules, as you could see in some dentinal tubules in here. And to get this information close, I have to compare such irrigant with other routinely used or commonly used root canal irrigant. So if I'm comparing with the 5% sodium hypochlorite and look for this photograph, I could see that there is obliteration or complete obliteration for the dentinal tubules. So I expect any interlocking between the relining material or the reinforcing material, or let's say the dentine substitute material which we are going to use, with the root canal dentine. If we compare the previous photograph with the photograph for the dentinal tubules, when 15% of EDTA as an irrigant was used, it's closely resemble the 20% lactic acid in its action. At a higher magnification, we could see the dentine matrix below the surface appear more closely arranged than at the surface. And a thermoplastizing gutta-percha technique was used to obturate the canal after tooth preparation. And there is a radiograph here to see the complete root canal obturation with the gutta-percha. Then a post space is start initiating by removing the percha. As we follow the guidelines, we try to keep a 5 millimeter as an apical, and we get rid of the other by creating the post space using the Gates glidden. Then we did apply a smooth trans-eliminating post number 3. But before applying or center in the root canal, we did lubricate such post, a plastic post, for its later removal. Before applying the flowable composite, the Optibond Sol Plus was applied in the root canal, the wall of the root canals. Then with the use of the Navy tip, 25 millimeter, we was able to inject the flowable composite around the plastic post and compact it inside the root canal. Then, as far as the plastic post was lubricated, and with the help of the needle holder, we was able to take the post out, leaving a very clean, regularly or normal, regular size root canal. And an X-ray was taken to illustrate that there was no voids, there is no filling defects within the lining or the reinforcing material that was surround the plastic post that relining the root canal, or to get the root canal back to its original form and shape. The experimental study was done to see how the flowable composite was able to penetrate the open dentinal tubule with the action of 20% lactic acid and irrigant. Again, at higher magnification, we could detect the loose collagen network represented the demineralized dentine matrix. Also, to understand why we do select the flowable composite rather than glass ionomer as a dentine substitute, here the SEM for the glass ionomer sample, where there is no evidence of penetration of the glass ionomer through the widely open dentinal tubule by the action of the lactic acid at the root canal irrigant. Then, within the normal or regular size root canal, we try to prepare the post space and applying a quarter post. The effective post was applied in this study, and we did clean the post. We used the double Q resin cement to cement the post in place by applying a finger pressure first. It stays for a while till we get the cement cured. Then we do apply the light curing for some time, it was 30 seconds, for complete sitting of the luting within the root canal. As you know that the quartz post was able to transfer or transmit some of the light inside the root canal to be able to polymerize the cement within the root canal or within the whole root canal, including cervical portion or the apical portion of the canal, above the apical seal for sure. Then, with the use of the polyester central incisor shaped matrix filled with the composite, we build up the coronal part of the tooth. And this was the labial view of the completed case. And here is the palatal view. And we were able to get this patient the follow-up after 1 year, and it could see there is no any signs of periapical lesion or change in the periodontium or any other manifestation that could be related to failure of the case. This was taken 1 year. Unfortunately, we was unable to get the patient back after a couple or 3 years from the treatment or from delivery of the case. The good thing also about this technique that I did use it in another case with internal resorption within the bulb chamber, but I was not sure that it started with the perforation from a previous dentist and ended with the internal resorption, or starts with the internal resorption and ends with the perforation within the coronal part of the bulb chamber. But I was able with the same technique to close the resorption or to close the perforation, and the patient is okay for 3 years now. Same technique. Which may arise that what about the fracture resistance? The technique is efficient to apply a good resistance to fracture for such tooth, and the answer comes with this graph. When we look for the graph, we could see that 15% EDTA, 10% lactic acid, and 20% lactic acid at the root canal irrigant with the conjunction with the use of flowable composite as a relining material or reinforcing material for the thin-walled root canal, or let's say as a dentine substitute, was able or were able to increase the fracture resistance. And there was no significant difference between the use of 15% EDTA and 20% or 10% lactic acid. However, if you look at the same graph, you could see the low fracture resistance when we use the glass ionomer cement as the light material or as a dentine substitute. So coming to the end, we can conclude from this study or this case report that this technique documents the short-term successful restorative by using the flowable composite, and prosthodontic treatment by using the quartz fiber post within the thin-walled or the flared maxillary central incisor, and it was okay to get the tooth back to normal function. I would like to thank you one more time for attending this webinars. Thank you.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator